The surgeon ensures he has all the equipment in place before making the incision.
So we have the instruments that we need, but we require earthen board.
Most of these patients will come with issues of heartburn, bloating, coughing, fullness, a lot of fullness, nausea and vomiting.
In Kenya, millions silently struggle with the burning discomfort of acid reflux, a condition known as gastroesophageal reflux disease or GERD. For many, simple changes in diet and medication offer relief, but for others, the symptoms persist, affecting their daily lives, their sleep, and even their mental health. Today, we take you inside a groundbreaking solution, a minimally invasive surgery that promises lasting relief. It's called laparoscopic heartburn correction surgery. In this episode, we will observe the delicate work inside the operating room and also consider aftercare. This is a story of resilience, innovation, and new beginnings, right here in Kenya.
My name is Stanley Mwenda Aruyaro. I'm a consultant surgeon and the chief medical officer in PCA Kikuyu Hospital. Today we are doing a procedure called Nissen fundoplication, and we are doing it by keyhole surgery. So essentially it is called laparoscopic Nissen fundoplication, which is a procedure to revert heartburn or reflux disease. Very common, if I may say, very common. Every week in the clinic, a patient will come and their problem is, I have a tummy upset, I have acidity, I have reflux. And therefore you assess that patient and you're able to establish whether they just have hyperacidity or if they have a mechanical problem at that junction between the food pipe and the stomach.
It presents as chronic heartburn that over time really now deteriorate the medical condition of the patient.
Several factors can contribute to hyperacidity. Let us look into some of them.
So there are two things to this. One is there is the acidity based, which is what we call the gastroesophageal reflux disease. And that has got several causes. Okay? Hyperacidity, everywhere you've gone, you've had patients say, I have H. pylori. So here we have a bacteria called Helicobacter pylori that contributes a lot to acidity because it has a way to attack our lining in the stomach and contribute to that problem.
Now, what are some of the symptoms of hyperacidity?
Most of these patients will come with issues of heartburn, bloating, coughing, fullness, a lot of fullness, nausea and vomiting. And to advanced cases, some of them come with even issues of swallowing. They're not able to swallow adequately and properly.
The lady undergoing the laparoscopic surgery came with particular complaints, which Dr. Aruyaro explains.
For this patient, they have the acidity, but upon investigation by endoscopy, we also established they have something we call hiatus hernia. What hiatus hernia means is where the gullet enters the stomach, that space is supposed to be tight against the gullet like this, but hers is a little spatulas like this. So that's one of the contributors to gastric contents or stomach contents flowing back into the food pipe and giving the patient acidity problems.
Before a patient undergoes surgery, they must go through a series of preparations.
So this patient has to be prepared from things that are very baseline. You have to first of all bring them to the ward so that we investigate them, do a full hemogram. How is their HB? How is their blood? Do they have pre-existing infections? Then, because these are patients who are supposed to take medicine, IV medicine, you have to investigate their kidneys. Some you may even need to do their lipid profile, their liver function test, because one of the causes of this hiatus hernia is obesity. So those are the baseline investigations. Then now when they're getting ready for surgery, we keep them nil per oral. So 6 hours before the procedure, they're not going to eat. The reason they don't take anything by mouth is because this procedure, we do it under general anesthesia. So where the patient is, the whole body is anesthetized. So therefore, for the risks of aspiration, what they had eaten before, we stop the patients from eating 6 hours before. But now during that period, they are not eating. We supplement them with IV fluids. The role of the fluids, one is to supplement now the energy requirement with dextrose, and also to do something we call fluid resuscitation that we always need to do before surgeries. And then we do something we call antibiotic prophylaxis before surgery. Studies encourage us to do antibiotic prophylaxis 1 hour before cutting, so that by the time you're cutting, the antibiotics are already at the incision site to prevent now those surgical associated infections from cutting.
Before surgery, the anesthesiologist performs a detailed assessment to ensure the patient is fit for general anesthesia. This includes checking the airways, reviewing medical history, and confirming there are no health risks. Once everything is clear, the patient is taken to the operating theatre for anesthesia induction.
After you do your antibiotics now, the patient is ready. Now we wheel them to the operation room. They are draped. The anesthetist is now putting the patient to sleep, and then a few nursing procedures such as catheterizing the patient, because you want to monitor your urine output.
We get into the theatre after following the usual safety and hygiene protocol. This includes scrubs, clean hands, a hairnet, and theatre shoes. We also sterilize all our equipment. Once in, we find that the patient has already been catheterized. Before any incisions are made, the surgical team begin with strict sterilization. A clean and controlled environment is created where equipment can be accessed during surgery. Every member of the team wears sterilized gowns, gloves, and masks. The patient's abdomen is thoroughly cleaned with antiseptic, ensuring the area is free from harmful bacteria. Once the abdomen is sterilized with antiseptic, the rest of the body is covered with sterile drapes, exposing only the surgical site. Next, the team hooks up essential lines. The theatre nurse helps to connect the various cables to the laparoscopic machine as the rest continue to sterilize the equipment. The various cables, such as the electrosurgical unit and other laparoscopic instruments, are carefully anchored near the surgical site. This is done to prevent them from shifting or touching non-sterile areas, which could compromise the sterile field. In theatre, instruments move in a controlled one-way flow from the sterile field to the surgeon, helping maintain a contamination-free environment throughout the procedure. The surgeon carefully marks the incision site on the upper abdomen, guided by anatomical landmarks, ensuring safe and precise access to the surgical area. Throughout the procedure, the patient's blood pressure, oxygen levels, and heart rate are closely monitored, ensuring stability and safety every step of the way. Just before the incision, the surgical team performs a final checklist, confirming the patient, procedure, surgical site, and equipment to ensure everything is in place. This crucial pause helps maintain safety and prevents errors. The surgeon ensures he has all the equipment in place before making the incision.
So we have the instruments that we need, but we'll require earthen board.
During the procedure, various cables and lines are used, including those for the laparoscopic camera, electrosurgical tools, suction and irrigation, anesthesia and oxygen, lighting, and patient monitoring to support both surgery and patient care. The surgeon makes a small incision in the upper abdomen. Once access is gained, carbon dioxide is carefully introduced into the abdomen in a process called insufflation. This expands the abdominal cavity, lifting the wall away from the organs and creating a clear, spacious environment for the surgeon to operate safely. The gas improves visibility and reduces the risk of injury during the procedure. Carbon dioxide is a safe, non-flammable, and easily absorbed gas by the body, with any leftover gas typically causing only mild, temporary discomfort such as bloating or shoulder pain. Once the abdomen is inflated with carbon dioxide and the working space is established, the surgeon inserts a trocar, a sharp, tube-like instrument used to create a safe and sealed entry point into the abdominal cavity. The trocar allows the insertion of a laparoscopic camera or surgical instruments without letting gas escape. This tiny camera provides a magnified, high-definition view of the internal organs on a monitor, guiding every move of the surgical team. With the abdomen inflated, the surgeon makes 5 small incisions in the upper abdomen and inserts trocars for surgical access. A camera enters through one port, while other instruments are inserted through the rest. Each tool is connected to cables for energy, light, suction, or irrigation, all organized to maintain a clear, sterile field.
Coming up after the break.
Number 2 is weight reduction. Usually when there's a lot of belly fat, then there's a lot of pressure coming back into the stomach from outside.
We are keeping them warm or just monitoring their temperatures until they are fully awake. So that then that patient is suited to be monitored in the ward.
Every step in the surgery is executed with precision and coordination as the team works seamlessly to ensure the best possible outcome for the patient. After the break, we shall keep following the surgery and also speak to Dr. Aruyaru one-on-one. Stay with us. And now for a short healthcare tip. To prevent heartburn, aim for smaller, more frequent meals throughout the day and avoid large meals or eating too close to bedtime. Stay away from trigger foods like spicy dishes, citrus, chocolate, and caffeinated drinks. Maintaining a healthy weight, elevating the head of your bed while you sleep, and avoiding lying down right after meals can help reduce heartburn and acid reflux.
We are living in a lost and broken world, constantly bombarded by messages of hate and atrocities. But with God, we can overcome. Find hope and restoration on the go through life-changing shows on the Family Media app.
And then you will lose yourself and gain the world. And Jesus said, what good is it?
Get to stream Family TV and Family Radio 316 straight from your phone. Catch up on a show you missed or create video streaming playlists by saving and watching videos from our huge variety of shows at your own convenience. Download the Family Media app, available for all Android and iOS users on the Google Play Store and Apple Store respectively. Family Media, keeping Jesus on the airwaves.
Welcome back. As we continue our journey through nascent fundoplication, we've seen the careful preparation and precision required to ensure a successful procedure. Now, let's dive deeper into the steps ahead as the surgical team continues their critical work of addressing the patient's condition. We can see the surgeon making incisions using a cauterizing blade which cuts tissue while simultaneously sealing blood vessels. The cauterizing blade is used to carefully pierce through thin membranes and tissue layers. These include the peritoneum, the thin lining of the abdominal cavity, as well as connective tissues around the stomach and esophagus. Each cut is made with precision to expose and access the right structures while minimizing bleeding and preserving surrounding organs. We can now see a variety of tools used to dissect tissue, cut, and cauterize blood vessels as needed. The surgeon continues to intricately guide the other members of the team as they work towards reaching the esophagus, all the while keeping their eyes glued to the screen. Throughout the procedure, the camera is carefully maneuvered to capture the action inside the body. The various instruments are visible as they work within the cavity, allowing us to see the precise movements and tools being used to navigate and treat the area. The surgeon also uses retractors, specially designed tools, to gently hold back organs like the liver and stomach, creating a clear path to the esophagus and diaphragm. As the surgical team carefully navigates through the abdominal cavity, they gradually move closer and closer to the esophagus. With each precise maneuver, the instruments probe deeper into the area, steadily revealing the structures they need to access. The camera continues to capture every delicate movement, offering a detailed view of the anatomy as the surgeon works their way towards the esophagus, ensuring they stay on track for the procedure. The team works in unison, carefully maneuvering around each organ in their path. Every movement is deliberate, with each member playing a crucial role in guiding the instruments with precision. This collaborative effort ensures that nothing is missed and every step is taken with the utmost care, allowing the surgeon to navigate through the delicate structures with ease. They eventually get to the esophagus.
This is esophagus I'm lifting out. This is the retroesophagus and this is retroesophageal scrotum. So I just need to, hapo mbele sina shida, but I need to come down distally here and see what I need to do with these tissues.
They carefully assess the position and condition of the esophagus. The surrounding tissues are gently maneuvered or retracted to provide clear access. The laparoscopic camera helps guide the surgeon's movements, ensuring they remain focused on the target area. We'll now leave the surgeon to complete the procedure as they carefully wrap the stomach around the esophagus, securing it in place to prevent acid reflux. Now, we step away from the operating theatre for a one-on-one conversation with the man behind the procedure, Dr. Stanley Aruyaru, the lead surgeon. For somebody who is not ready for surgery, what lifestyle modifications can they make to live with this condition?
Thanks. That's a very valid question, a very good one, because not many of the patients are interested or ready for surgery at the first go. So what we do is we will start, of course, first with the medications. But then we give lots of modifications. One modification comes around smoking and alcohol intake. So we tell them stop if you can, reduce if you can't stop. But ideally, if they're able to stop, that is good enough. Number two is weight reduction. Usually when there's a lot of belly fat, then there's a lot of pressure coming back into the stomach from outside, from the belly fat outside the stomach. And that might be contributing to the pressure inside the stomach that is pushing the contents back into the esophagus. So when the patient is able to lose some weight, then that helps. And number three is now in terms of position. If you assumed that when a patient is lying flat, that whatever is in the stomach is flowing back to the esophagus, then you can imagine if you tilt them up a little bit, that then whatever wants to flow back to the esophagus will be going against gravity. So that is pure physics and pure gravity. So we encourage patients to prop up the bed or lie on 2 or 3 pillows. That will help so that it doesn't flow. Then we talk about food. We talk about how much can you take. Most of us will remember when we were growing up, for those who grew up in the village, during Christmas, we'll go from homestead to homestead, eating. By the time you are done with going around the village, the stomach is so full you can't even sit upright. You are sitting at an angle and you are always belching. So that tells you that if you overfill the stomach, that neck that is supposed to create, a barrier mechanism is completely lost. Take the example of a balloon. If you blow the balloon just a little, it will have a long neck. But the more you blow into the balloon before it bursts, it will have eaten into the neck. You can't even see where to tie. So that is the assumption that patients have to have in their mind, that if you fill the stomach completely, then that area is supposed to, it's supposed to have a sharp angle. We call it angle of ease. Over time, when the stomach is completely full, then that angle is interfered with, and therefore then food can come back. So we tell the patients, don't overeat and avoid taking water after meals. It's easier to just take water or liquid as you feed, because if you now finish the dinner, for instance, and you come take a glass of water, then the water is floating on top, for lack of a better way to explain it, and it's easier. That is easier to reflux than if it's part and parcel of the solid food you've taken. And then finally, of course, is the issue of timing between eating and sleeping. If someone eats and sleeps immediately, they wake up feeling, I feel like I haven't digested my food, I feel like I'm bloated, it's something I feel I'm having heartburn or something like that. It's the same. So you tell them, if you sleep at 9 p.m., eat by 6, by 7. If you have 2 to 3 hours of, being upright and the food has been, emptied out of the stomach. We encourage patients to chew gum. It's an interesting thing. Patients look at me and wonder whether I'm joking. But ordinarily, patients with reflux subconsciously swallow saliva a lot. Subconscious because when the acid comes up, it is natural to swallow saliva, to just have the cleansing mechanism, just the physical sweeping of whatever acid is coming up. But the second bit is because saliva is basic. It has something called salivary bicarbonate. So when it comes, it's able to kind of neutralize the acid and reduce the acidity up. There is a question I usually don't like to go into, which is what can I eat, what can't I eat? Because you become so prescriptive and you can't quite tell what the patient will eat. You give them a list, and the list you've given them is only available to people who probably reside in the coast, and the patient lives in northeastern. So the thing is to tell the patients, you know your body well, you know what food gives you trouble. Avoid that if you can, and if you have other ways and other sources of nutrition, then as long as you have a balanced diet, avoid the food that causes you trouble, and then follow all these other lifestyle modifications. So we do those, and they work. They work for quite a number of people. And some people come and say, I'm okay. After 2 months or 3 months, I even stopped my tablets. I'm doing okay. Other days, they come and say it's bounced back. But as we mentioned earlier, Patients like the one we have will come and say, yeah, I know medication works, but I'm done with medication. I just want a surgical option. And that is not, it's not a bad thing to say, because surgery is scary, but also surgery is safe.
Post-operative care after a nascent fundoplication is a critical part of the recovery journey, designed to ensure the patient heals well and experiences lasting relief from acid reflux.
Aftercare is very important from the point where now the anesthetic agents are reversed and the patient is now awake. We observe the patient at PACU in theatre, where we want to observe how the patient is coming around. We are monitoring their vitals, their blood pressure, how they are saturating their oxygen. We are keeping them warm or just monitoring their temperatures until they are fully awake. So that then that patient is suited to be monitored in the ward. When they come, we keep them nil per oral 6 hours after the procedure. We don't want them to eat because of the same issue of, like we are still reversing the anesthetic agents. We fear aspiration pneumonia is one of the main risks anticipated. But from there now we want to introduce feeding. Meanwhile, during that time when they're not feeding, we have already started our antibiotics. We have now this one, we had started 1 hour before, we maintain them on the antibiotics. Then you're monitoring your vitals, and now you give fluids to fluid resuscitation post-surgery, and also maintaining some dextrose because the patient is not feeding for caloric requirements. Then from there, now bringing the patient back to feeding, you introduce them slowly. What we say, you gradually introduce the feeds. So you start with sips of water, then they can have a cup of tea. That's post the 6 hours post-surgery. Then you go to light diet, and you observe how the patient is tolerating. Also, this period post-op is where you want to do your abdominal exam and also let the patient confirm to you that they are pus inflators. And also you auscultate for bowel sounds, because now you want to know, we were doing an abdominal surgery, so you want to know whether the bowel sounds are back, then which is a very safe place now to start your feeding and everything. As you monitor also the incision sites. So you're monitoring them for signs of, you see now with laparoscopy we have a few incision sites where we put the scope and now the knives and everything. So now you're monitoring those time. They are small incisions actually, which is one of our advantages with laparoscopy, but you're monitoring how the wound is healing. Is it clean? Is it oozing? In case you maintained the patient on a drain, how much are we draining? Are we draining blood? What are we draining? How much? Yeah.
The patient's surgery went smoothly from start to finish, and in our follow-up with the hospital, we are happy to report that she made a full recovery. And that brings us to the end of today's journey inside the operating room. From the first incision to the delicate wrapping of the stomach, we've witnessed the precision, teamwork, and innovation that define modern laparoscopic surgery. We hope this glimpse into the world of medicine has left you both informed and inspired. Until next time, stay curious, stay healthy, and thank you for watching Family Health.